I'm sorry, I have one more question. So do you have any advice for those who do not have access to, like cycloplegic drugs who are practicing in, independent practice in an optical setup?
Yeah,
How
thanks for
should they?
this question, ma'am. So dynamic retinoscopy plays a crucial role here. So as I mentioned, you do the dry retinoscopy, what we do in a day-to-day clinic, as well as we can do the dynamic retinoscopy as well to rule out the response of the accommodation. If dynamic retinoscopy is okay, then you can do the cover test as well to rule out any ESO deviation as well, because most of the cases are coming with the accommodative spasm that can be ruled out with the dynamic retinoscopy as well. Because in dynamic retinoscopy, the normal dynamic retinoscopy is with the MEM is plus 0.25 to plus 0.75 diopter. If it is going in lead of accommodation and in vacillation is also there, like your dry retinoscopy, then it's suspicious as a accommodative spasm of near reflex.
Okay, thanks.
Thank you. Next, Optum Rupesh Mehta, may I know you are ready to present? Okay, thank you.
Hello, am I audible?
Yes.
Okay. So can I start? Change please.
Yes, please proceed.
Okay. So just like okay. Good afternoon, everyone. My name is Rupesh, contact lens consultant at KBC Campus Vijayawada. Today I am going to present a case presentation, and the title of the case presentation is piggyback contact lens system in ocular trauma and aphakia. So before moving to the case presentation, here I would like to explain a little bit more about what is ocular trauma. So if you talk about the ocular trauma, it refers to an eye injury along with surrounding structure that is basically caused by blunt, penetrating or chemical injury that affect the eye. It is one of the most major cause of the avoidable blindness. If we talk about its prevalence, there is a study, meta-analysis study that estimated that approximately 3.75% of the Indian population has sustained ocular injury that can leading to the visual impairment and blindness, equating to around 3.73 million individuals. So to manage this type of ocular injury, like it is important to relieve the pain, prevent further damage to the eye, and improve visual outcome after post-trauma. So this is the demographic details of the patient. A 10-year male child and a student resident from Vijayawada, Andhra Pradesh, has presented to a cornea clinic for the first time with a complaint of sudden painful loss of vision in the right eye associated with bleeding and watering. So he had an injury with wooden stick in the right eye 1 day ago. After post-injury, he consulted to local hospital. There the child was diagnosed at right eye corneal tear and has referred to LBPI for further investigations and the management. So if we talk about the visual acuity, distance visual acuity in the right eye was PL plus PR inaccurate with less than N36 for the near. In the left eye, it was 20 by 20 with N6. So in this visit, refraction was not performed and the child was very symptomatic even to the light as well. So this is the clinical slit lamp photo of this child where we can see that this is the clinical slit lamp photo of this child where we can see that there is a full thickness corneal tear of approximately 6 millimeter extending from 3 o'clock to 9 o'clock, extending with iris incarceration with shallow AC. So based on the patient complaint, clinical finding, the child was diagnosed as right as open globe injury penetrating type zone 1. So the patient had posted for the surgery. The surgery was performed like right eye corneal tear repair plus anterior vitrectomy plus paraplanar vitrectomy with vitreous biopsy. So this is the post-op 1 day image of the patient where we can say that there is a suture intact extending from 3 o'clock to 9 o'clock with surrounding corneal edema and the AC was shallow. So here after that patient was lost to follow up and again come after 1.5 years to the cornea clinic with a complaint of photophobia in the light and also inability to open his right eye during the bright light. So here in this visit we record the unaided visual acuity in the right eye was CFCL with 20/20 in the left eye. So in this visit the patient was non symptomatic, so we performed the objective refraction which reveals plus 13 diopter spherical with 5.5 diopter cylindrical at 20-degree axis in the right eye. And in the left eye, plano with 0.5 cylindrical at 180-degree axis in the left eye. So the subjective acceptance in the right eye was plus 13 diopter spherical, with which the visual acuity is improved to 20 or 125 for the distance, and N24 at the 30 centimeter further near. In the left eye, patient did not accept any power, and the visual acuity was 20/20 with NC. So here the patient I referred to the contact lens clinic for the contact lens trial. The child was very neophyte to contact lens. So I explained that what are the different modality of the lenses, cost line with the care and regimens, and the parents were willing for the trial. So before proceeding with the trial, I sent the patient for the corneal topography, which way in the corneal topography, we can see that there is irregular cornea with high astigmatism. So based on the corneal topography, I select the base curve. So I try the multiple contact lenses, but the final contact lenses was a base curve 7.90 with a power of 10 diopter spherical, diameter 9.8, and the lenses was classic corneal GP lenses. So after the lens insertion, I sent the child for the adaptation time. After 1 hour of the adaptation time, the child was comfortable with the lenses, but the main complaint of the child was he is unable to open his eye at the sunlight. So this is the clinical picture of the child where we can see that there is a scar extending from 10 o'clock to 9 o'clock along with the pupil was dilated. So based on the patient complaint and clinical picture of this child, we given the option of piggyback contact lens system and explain to the parents in the details regarding that lens care and regimen. The parents were willing for the trial. So here we try the piggyback contact lens system. Piggyback contact lens system itself indicates the two lenses, soft contact lens over the hard lenses. So the soft contact lenses was the purican prosthetic lenses with the base curve median, power 0, diameter was 14.50, and the purican prosthetic lenses was type C. So in the purican prosthetic lenses also we have the different lens type. Among them, one is type C, where the pupillary like visual axis is clear and the rest of the part was opaque. So over that, we also put that corneal GP lenses of base curve 7.9 and power plus 10 with the diameter 9.8. The lens was corneal GP lenses. So we did the over refraction over the contact lenses. Over refraction was 0.5 diopter spherical and the acceptance was 0. And the visual acuity was improved from 20/100 to 20/50. And this is the clinical picture where we can see that this is the corneal GP lenses, and below that there is purican prosthetic type C contact lenses. So here we fitted with piggyback system in the corneal tear repair and the aphakia. So the take home message from this case presentation is like early intervention in case of open globe injury is critical to preserve the patient vision. And in case of pediatric aphakia with the corneal opacity required a tailored visual rehabilitation. And also piggyback contact lens system improve both comfort as well as the vision in cases of irregular astigmatism and also in case of corneal scarring. In case of piggyback contact lens system, we put the two different lenses. One is a soft lens, over that we put the hard lenses. So make sure that the soft lens should be of the high decay material that allows the better oxygen permeability and the patient tolerance as well. So to conclude this case, there are the few literature which suggested that the piggyback contact lens system can be helpful in terms of vision as well as also in terms of the comfort as well. And also the patient who is intolerant to the corneal GP lenses. And also these lenses, in these lenses, we are putting two lenses, like combination of two lenses. So make sure that there should be like high oxygen permeability lenses that will give you the more comfort as well as the more visual acuity should be improved, and also the patient should be comfortable. Thank you so much, and I am open for any question.
Thank you, Rupesh. It was a very interesting case of, handling two lenses for the same eye. Well managed. I'm just curious to know, like, why you did not consider scleral lenses or any other type of specialty lenses, or was it tried and decided not to be, prescribed?
No, ma'am. So like before, like whenever the patient is going to the contact lens clinic, those patients who are neophyte to the lenses means new to the lenses. We have to explain this all the things like cost, language care, and regimen. So the patient is not from the good background and like economic background. So and also that with the RGP lenses, the fitting was good, and also the patient was comfortable and the visual acuity was good. But the main concern of the child was like he's having the photophobia because the iris was completely absent and also the pupil was dilated. So you put the Purican prosthetic lenses over that RGP lenses, and the child was comfortable and happy in terms of the vision as well as the comfort as well. So like so that we didn't try the scleral lenses as well. There are the few cases where if it's difficult to fit that RGP lenses, so we can go for that scleral lenses as well, no problem. But it depends upon the case to case. When the case get advanced, the modality of the lens is going to be changes.
Okay, in this particular case, why did you decide not to prescribe scleral lenses?
Because in these cases, like the fit of the corneal GP lenses were very good. Like
Okay.
and the
Okay,
patient.
you felt it was not necessary. Right. All right, got it.
Rupesh, a great point to explore here. What was the subjective acceptance? It's just plus 13, I believe, right? Was there any astigmatic component in the subjective refraction before contact lens fitting?
No, ma'am. Before that, the whatever that irregular astigmatism is there, that was corrected by the corneal GP lenses. So over the
No.
refraction.
What is the refraction? What is
Refraction
the refraction?
plus 10 after spherical, ma'am.
Only spherical. So why
Yes,
didn't you just stop with the prosthetic type C lenses? What is the need for RGP here?
so RGP basic, the as we look at the clinical picture, that the surface of the cornea is irregular last month. That
I
corneal is
understand, but that surface is not giving you any cylindrical. Okay, in your case, I didn't see this number. In
but in the
case thing you have submitted only plus 13 diopters, I believe.
yes, ma'am.
Yeah,
So,
subjective acceptance is 13 diopters. That is what is there.
yes, that is the spectacle subjective acceptance. Over the contact lens acceptance, there was the patient didn't receive any power. There was 0.5 spherical.
So subjective acceptance being 13, did you check the vision with just the prosthetic lenses?
With this though, I didn't check the lenses because
instead of going for a two system, if the prosthetic lens is going to give the same vision as the piggyback system, then we might not know, no, because your cylinder is not reflecting on the subjective acceptance. In that curiosity, I am asking.
So, ma'am, actually, this is the spectacles acceptance. If you look at the visual acuity also, that is 20 by 125. But with the contact lenses, visual acuity is improved to 20 by 50 because that whatever the irregular astigmatism was there, that is masked by the corneal GP lenses.
Okay, thank you.
Thank you. Next Optum Kalagaria Bhagyalakshmi, case number 013.
Good afternoon, everyone. Am I audible?
Yes, you are audible.
Is my screen visible, sir?
Yes. Please go ahead.
Good afternoon, everyone. A special greetings to the judges. Now, myself, Bhagyalakshmi, I'm working as a consultant optometrist at LV Prasad Eye Institute, Vizag. Now, I'm going to discuss with you all about choroidal mass with associated subconjunctival lesion. Objectives are to discuss clinical and imaging features of choroidal lymphoma and evaluation of choroidal lymphoma through systemic features also, and to look at differential diagnosis and management of choroidal lymphoma. Coming to introduction, lymphoma is characterized by neoplastic proliferation of the immune system. Sir, 1 minute. Lymphadenopathy and its related symptoms, whereas ocular manifestations are Hodgkin's disease, which consists of anterior uveitis, vitritis, and multifocal fundus lesions. which looks like chorioretinitis, and non-Hodgkin's lymphoma can manifest with conjunctival involvement and Mikulicz disease, Mikulicz syndrome, nothing but lacrimal gland inflammation and uveal infiltration. And CNS B-cell lymphoma may be associated with intermediate uveitis and sub-RPE infiltrates. Coming to the case, a 39-year-old female presenting with a complaint of persistent redness since 6 months. There is no history of head or ocular injury. Previously, somewhere else diagnosed as left eye episcleritis. There they have given some topical steroids, but it is not resolved. There is no complaint in the past, same complaint in the past or systemic complaints. There is no history of TB. There is no history of recent onset fever or skin lesions. Coming to the vision, both eyes are emmetropia and IOP is within normal limits 10 mm Hg. Coming to right eye slit lamp findings within normal limits, whereas left eye shows there is sectoral diffuse scleral congestion superiorly here we can see, which looks like a salmon colored mass lesion where there are vessels looks like corkscrew vessels. And coming to fundus imaging, right eye shows within normal limits, left eye shows some RPE changes here and ILM folds over here, and peripheral shallow choroidals we can see here. Coming to autofluorescence, there are some stipple autofluorescent pattern we can see here. And coming to OCT, there is some irregularities in RPE and all retinal layers are intact, but the thickness is increased. Like the foveal contour is good, so the vision is preserved in left eye. Coming to B scan, here we can see thickened RCS complex, and here there is a choroidal mass lesion in this axial scan. Choroidal mass lesion straddling the optic nerve through this axial scan, we can see here. The provisional diagnosis is left eye choroidal mass lesion with associated subconjunctival mass, whereas differential diagnosis is like choroidal melanoma, secondary choroidal metastasis, and the choroidal lymphoma, atypical unilateral uveal effusion syndrome. Coming to the management, firstly, we advise for some few tests, basic tests like CBC, RBS, HP shows within normal limits, and ESR, CRP, C-reactive protein are also within normal limits, and TPHA, HIV was non-reactive. The important scan, PET scan, positron emission tomography is within normal limits. Serum lactate dehydrogenase test is also within normal limits. So advised for conjunctival biopsy. So here is the post-conjunctival biopsy slit lamp picture. Here we can see. So HPE shows the features suggest of lymphoproliferative disorder, whereas few IHC markers which confirms the diagnosis of choroidal lymphoma. These are the IHC markers CD3, CD5, CD20 positive, and BCL2 and KI2 positive. These are the important IHC markers which confirm the diagnosis is like non-Hodgkin's lymphoma, where there is conjunctival involvement here in this case, and HPE shows the low-grade B-cell NHL with extranodal marginal zone lymphoma. Coming to the management, here the patient is given option of low-grade EBRT versus low-grade boom radiotherapy. The patient is currently underwent multiple settings of EBRT under oncologist provision. So, to follow the patient for assessment after EBRT. And coming to discussion part, ocular lymphoma, which is a rare entity, where we can see 8% of it extranodal lymphomas. These are like slow in growth, indolent tumors, like grows very slowly, whereas 30% of conjunctival lymphoma arise from orbital lymphoma or associated with systemic lymphoma after diagnosis. Most conjunctival lymphoma are of B-cell origin arising from MALT, whereas it is mucosa associated lymphoma tissue tending to be like which grows very slowly. The treatment options like low-dose systemic radiotherapy, EBRT, systemic steroids, oral chlorambucil. These are the case summary what we have gone through. And takeaway points like choroidal lymphoma can manifest with associated conjunctival mass. Histopathological and IHC studies helps in accurate diagnosis. Systemic versus localized therapy are available for treatment options. And thank you. I'm very grateful for this opportunity, ma'am. Thank you.
Thank you, Bhagalakshmi. I mean, it's definitely a very interesting case. So my question is from the optometrics point of view.
Mm.
How do you think, like, I mean, have you followed up this subject, I mean, this patient for quite some time? How long was the follow-up? And what was the change in refraction and vision?
There is no change in refraction because here we have taken the conjunctival biopsy, right, ma'am? So there is no change in vision. Vision is good actually in all the visits. Here the patient is followed up about 1.5 months, ma'am. Like today, she will come for the post EBRT ocular follow-up today. Today
So
actually,
what will be the optometric management of this?
like first we have to ask them the redness related part, ma'am, like how long it is. The basic history helpful for the diagnosis by the ophthalm.
Okay, thanks.
History management. Yes, ma'am. Thank you.
Thank you, Bhagyalakshmi. My question was also similar to Veena ma'am. So thank you. We will move on to the next presenter.
Thank you, ma'am. Thank you.
Thank you. Next is Optum Dhanalakshmi S, case number 014. Optum Dhanalakshmi S, case number 014. Optum Dhanalakshmi. Okay, we'll move on to next one. Optum Rahul Gurunathan, case number 015. Optum Rahul Gurunathan, case number 015.
Is my voice audible, sir?
Yes, both are visible and audible. Thank you.
Good afternoon, everyone. I am Rahul Gurunathan, optometrist, Department of Binocular Vision and Vision Therapy, Shankar Nethralaya and Unit of Medical Research Foundation. Today, I will be discussing a case of accommodative spasm where the diagnostic approach extended beyond the typical near triad assessment. Before moving into the case history, let's have a quick brush up on accommodative spasm. Accommodation is the process by which the crystalline lens increases its dioptric power to focus on near object as described by Hofstetter and Sufferda. However, when this response becomes excessive and involuntary, it leads to accommodative spasm, also known as accommodative excess hyperaccommodation or ciliary spasm. Cause and risk factors. Accommodative spasm is primarily caused by psychogenic factors, making stress and anxiety are the most common triggers. Physiological causes include excessive ciliary muscle activity and increased lens flexibility. Additionally, medical and neurological condition may also play a role. Other risk factors include uncorrected hyperopia, prolonged near work, all of which can aggravate the condition. Prevalence, a Chinese study found 37.19% of school-age children exhibited signs of accommodative spasm. Fluctuating vision, headache, photophobia, eye strain, double vision, eye pain are the clinical symptoms. More minus in dry refraction, less plus or plano in cycloplegic refraction, lead in dynamic retinoscopy, possible ESO deviation and pupillary miosis are the clinical signs. Background of the study, current case reports mainly focus on improvement in functional aspect of accommodative spasm in pre and post intervention. But in this case, report aim to highlight the impact of documenting the ocular biometry parameters pre and post treatment. Here we discuss a 14-year female who presented with headaches and sudden onset blurring of distance vision for the past 1.5 months. She was previously diagnosed with optic neuritis and treated with IVMP. Her medical history includes chronic sinusitis for since 3 years and allergic to sulfonamide. Currently, she is on oral prednisolone and famotidine. Initial ocular examination in OPD, distance visual acuity, right eye 6/6 and left eye 3/16 in Slavin chart. Near visual acuity N6 in both eyes. Vacillating reflex was observed in retinoscopy. Pupil response was within the normal limits. There is no anisocoria, briskly reactive to the light reflex. Ocular motility of both eyes full, free and painless. Color vision of both eyes within the normal limit. Slit lamp examination of both eyes, anterior and posterior segments were within the normal limit. Cycloplegic refraction was performed using 2% of homatropine eye drops. To establish baseline ocular biometry parameters, axial length measurements, right eye 23.94 mm and left eye 24.04 mm. Lens thickness, right eye 3.70 mm and left eye 3.86 mm, and anterior chamber depth, right eye 3.72 mm and left eye 3.68 mm. Here, there is no significant difference between the axial length because axial length is, was within the normal range, but there is a asymmetrical difference in the right eye and left eye in the lens thickness. Then she was referred to binocular vision clinic to investigate possible anomalies. Unaided distance visual acuity 6/7.5 in the right eye and 6/18 in the left eye, and unaided near visual acuity N6 in both eyes. The refractive error range measured with the VAM 5500 open field auto refractor varied between -3 diopter to -4.50 diopter in the right eye and -3.75 diopter to -5 diopter in the left eye. Objective refraction measured using open field auto refractor indicated varying levels of myopia in both eyes. In dynamic retinoscopy, lag to lead of accommodation was noted. Objective accommodative response, lead of accommodation up to -1.5 diopter in both eyes was noted. Management and treatment, the clinical findings including vacillating reflex observed during retinoscopy, fluctuations in accommodative response and asymmetry in lenticular parameters between the two eyes indicated the diagnosis of bilateral accommodative spasm. The patient was prescribed 1% of atropine sulfate eye ointment and advised to administer twice daily for 3 days to alleviate the accommodative spasm. Then the patient was counseled regarding the possible side effects of atropine, such as increased light sensitivity and potential dryness of the eyes. And a cycloplegic refraction conducted on the 4th day revealed a resolution of the accommodative spasm with retinoscopy shows no longer vacillating reflex. The patient was advised to return after a 21 days of atropine washout period for further evaluation. During the post-mydriatic test, retinoscopy was repeated, confirming the absence of a vacillating reflex. Ocular biometry was repeated and compared with the baseline values. So there was no changes in the axial length. Almost axial length looks within the normal limit, but in the lens thickness before and after treatment showing a significant difference. In right eye, there was a difference of 0.47 mm and in left eye 0.62 mm. Significant difference was noted. Discussion. This case reports highlights the occurrence of bilateral accommodative spasm. Spasm in the ciliary muscle causes a temporary shift towards nearsightedness due to changes in the zonal tension. Bolsam et al. In 2007 reported that during physiological ocular accommodation, the anterior surface of the lens moves forward and on average change in the lens thickness 0.063 mm in an emmetrope for 1 diopter of accommodation. Praveen Kumar et al. In 2022 reported a case of accommodative spasm post-injury, diagnosing via ocular biometry, noting a 0.15 mm decrease in lens thickness. In this case, showed a forward shift of the crystal lens measured at 0.47 mm in the right eye and 0.62 mm in the left eye using non-contact biometry. The temporary displacement of the crystal lens could explain the compromised distance vision. Conclusion, accurate diagnosis of accommodative spasm requires cycloplegic refraction and thorough clinical assessment, particularly in cases of mild accommodative spasm with relatively good visual acuity. Comparing lens thickness before and after using a cycloplegic agent like 1% atropine is vital diagnosis for accommodative spasm. Objective measurement of ocular biometry are crucial for evaluating and managing unique presentation like accommodative spasm to objectively document the structural changes in the lens and improvement in the ocular biometry parameters. These are the references for this case report. Thank you.
Time out.
Thanks, Rahul. I mean, very useful and need of the hour presentation. One question I have is like, what was the final management for this patient? Like, was the child asked to continue the atropine, or was the child given any home exercises or like in clinic exercises, or what was the final management?
At the post-mydriatic test, there was no vacillating reflex was noted. So finally, we conclude accommodative spasm was relieved. So the patient was advised for a vision therapy exercises using high plus with low plus accommodative flipper exercise, and also counseled about visual hygiene to maintain the near working distance and room light condition, everything, ma'am.
Thanks.
It was a clear, interesting presentation. In case, what made you to think that you need to do all this biometry changes? Is it very essential to be documented in all cases coming like this?
Yes, ma'am. In all type of accommodative cases, we cannot see a possible ESO deviations, because all the literature is only looking into the functional parameters. So that's why I'm going beyond. Is there any structural changes in the lens? That's why we made this thing, ma'am.
Very interesting. Thank you.
Yeah, thank you, ma'am.
Thank you.
Thank you, sir.
Okay, next we move on to Optom Krishna Shah, case number 016. Optom Krishna Shah, case number 016.
Is my screen visible, sir?
Yeah, yes. Visible and audible.
So shall I start?
Yes, please.
So good afternoon, everyone. Myself, Krishna. Today I'll be presenting on topic enhancing visual comfort in ADIS pupil, a case report utilizing prosthetic contact lens and near corrective glasses. So these are the outlines of today's presentation, and these are the abbreviations used. And moving on to the introduction part. So as we all know that Eddystonius pupil is a neurological condition which is characterized by a pupil that is larger in size than normal and which reacts slowly or not at all react to light, and as well as which constrict during near focusing object. So these are the conservative management for Eddystonic pupil, which includes reading glasses, low dose atropine, and photochromatic glasses and sunglasses. So moving on to the case detail, this is a case of a 28 years old male who is an IT professional who came to a clinic with the complaint of blurring of near vision, and he had difficulty in bright light outdoor, as well as he was more concerned about the cosmosis that he noticed a white reflex in left eye during night photography, and he didn't have any history of any trauma, surgery, laser, and use of any medication or any allergy. So upon initial examination, we found his base corrected visual acuity was 6.6 in both eyes for distance, and cycloplegic refraction was similar to the acceptance, but his near visual acuity was significantly reduced to M12 at 30 centimeter. So upon clinical examination, we found that anisocoria was noted, and the pupillary measurement shows that right eye the pupil was normal, which is 3.5, and left eye the pupil size was slightly larger, so which was 7 mm. So the patient was prescribed for this pilocarpine test, which was positive in left eye. So which showed the diagnosis of Eddystonic pupil. So moving on to the further management, the patient was referred to binocular vision department clinic for further management, as the patient was having near vision difficulty and difficulty in viewing computers. So BV assessment was done, and upon assessment, we found that the stropsis was impaired and amplitude of accommodation in the left eye was reduced, and as well as MEM was also reduced. There was a high lack of accommodation. So corrective addition glasses of 2.25 was prescribed to the patient in left eye. And for further management, as the patient concerned was photophobia, difficulty in opening eyes outdoor, as well as cosmosis, the patient was hence referred to contact lens department. So a prosthetic type C contact lens was tried with a clear pupil and tinted iris. So these are the trial lens parameters, and the fitting was optimal, and these are the over refraction value, and these are the acceptance. So this is the final prescription in which a small modification was done, was the modification in the pupil size, which was 4 mm, was given. And following the trial, the patient felt a significant reduction in photophobia. He was able to open eyes outdoor, and better cosmosis was obtained. So the patient was prescribed with a combination of prosthetic contact lenses, Type C contact lens, and corrective addition glasses. And he was advised to come for follow-up after three months. So on follow-up visit, again, BB assessment was reassessed, in which there was significant improvement in stereopsis, and amplitude of accommodation was normal, and there was normal lag of accommodation. So at this visit, the patient was comparatively comfortable at near vision. He didn't have any difficulty in near vision and all, and astigmatic symptom was reduced, and photophobia issue was also done, clear. So moving on to discussion. So these are the traditional management or treatment in Aedes pupil, which has been followed in long decades, as I already discussed previously. And photophobia, commonly pilocarpine has been used to treat Aedes pupil, which helps in reducing the lag of accommodation and improve near vision. But this pilocarpine often limits some ocular side effects, which includes like spasm of accommodation, and as well as blur vision, which leads to blur vision, headache, and all. And there might be like constriction of people might have a difficulty in near vision, and the concentration also not readily available. So hence, in this case, we have done a trial of prosthetic Type C contact lenses, which significantly reduced the photophobia, glare sensitivity, and patient cosmosis is also better, which was aligning with the previous literature. And also, there was a study done by Korani et al., in which he compared prosthetic contact lens as well as pilocarpine effectiveness, and he found that prosthetic Type C contact lens was more effective in reducing contrast sensitivity as well as glare. So moving on to accommodation, present case exhibits the lack of accommodation in the left eye, which was edystonic eye. So literature also says that like edystonic eye will have a higher lag of accommodation. So moving on to the next study, which was done by Radhakrishnan et al., in which they found that the use of prosthetic contact lens may not induce any significant accommodative effect. But in our case, in present case, after 3 months of contact lens uses, there was significant improvement in accommodation, stereopsis, and MEM value. So this could be due to the prolonged near work with contact lenses might have induced a training effect, improving accommodative control, which supports the existing literature, which was done by Wegener et al. So thus, I'd like to conclude that a dual approach management using combination of prosthetic Type C lenses and additive lenses was more effective to reduce the symptoms of Aedes pupil, and holistic management approach enhances the overall patient comfort and satisfaction. So these are my acknowledgement. Thank you.
Thank you, Mr. Krishna. It was a very interesting approach of, like handling Aedes pupil. So my question is like, was there another alternative for this? Like, since anyway you prescribed glasses over the contact lenses, why didn't you like try like something like a photochromic lens to reduce the glare? Was there any specific reason why you tried this, Type C contact lens?
Yes, ma'am. Like the photochromic contact lenses will help in reducing the cosmosis or like brighter light, but it do not have made more effect in accommodation, ma'am. Reason like we have tried these lenses, and patient was very concerned about the cosmosis. Like you don't want to wear extra glasses over the lenses, and that was the reason.
I thought you mentioned you had prescribed glasses over the contact lenses somewhere.
Yes, ma'am. Initially we have prescribed because he had a high lag of accommodation and he was having difficult near vision difficulty.
Sorry, I mean, we didn't get you in the last.
So initially we have prescribed the ad because he was having significant near vision difficulty, ma'am. And prescribing contact lens was the main reason for photophobia. He was not able to open the eyes moreover, and he was more concerned about the cosmosis.
All right.
Can you go back to your previous patient details? Stop. Next slide. Your aim was to correct for the prosthetic cosmetic appearances, right? Or
Yes,
was
ma'am.
it like to improve the accommodation? Next slide, please.
No, ma'am. The main concern was
Next slide. You have spoke about accommodation. No, how did this relate to your study?
Yes, ma'am. Actually, initially we have done for the cosmosis purpose, but significant improvement in BB parameters was also improved. So thus we have prescribed this as a
Was the
mode of
patient
treatment.
followed up in the binocular vision clinic also?
Yes, ma'am. This whole assessment has been given from the binocular vision clinic only.
Okay, thank you, ma'am.
So the reporting is actually that improving this binocular vision as parameters also. There was a study done in this. They have said that continuous use of contact lens might induce adaptive changes in the visual system and enhance the ability of maintaining the near vision as well.
Moving forward, if you're thinking of publishing this, probably the aim with which you started was to give a cosmetic outcome. Okay, but you
Yes,
ended
ma'am.
with the binocular vision assessment. Okay, so you need to redefine your purpose when you're doing any presentation.
Okay, ma'am.
Thank you, ma. Thank you.
Okay, thank you so much, ma'am.
Thank you. Next, Optum Versa Harinia M, case number 018. Optum Versa Harinia M. Yes.
Is my screen audible, sir? Sir, visible, sir?
Visible and audible.
Hello, am I audible?
Yes, ma'am. Go ahead.
Is my screen changing, sir?
Your voice is actually breaking.
Am I audible now?
Your voice is feeble.
I'll come up with a better.
Okay, okay. We will move on to next one. Optum Janani Balaji, case number 019.
Oh, yes.
Optum Janani Balaji, case number 019.
Is my slide visible, sir?
Yes, yes.
Sir, is my file visible?
Your presentation is visible. Please go ahead.
Okay. So, good afternoon. I'm Janani, optometrist from Shankar Nethralaya here with the case of management of post-cerebellopontine angle tumor exertion, ocular complications with scleral lenses and low vision aids. So CPA is a wedge-shaped cisternal space within the posterior fossa, and tumor exertion in this region can lead to various ocular complications like facial nerve palsies and visual impairments. And studies have reported the efficacy of surgical and topical management for this condition, whereas this case report highlights the importance and the role of low vision aids and scleral lenses in rehabilitation. So here I present a 26 years old female presented with the complaints of progressive painless blurring of vision in both eyes for past 9 months, and these complications arised following a surgical excision of left-sided CPA tumor. Post-op, her best corrected visual acuity was 6.9 in right eye and 660 in left eye, and patient has also developed a left-sided facial palsy causing nystagmus and lag of thalmus, and for which she has undergone torsography and facial reconstruction surgery elsewhere, and she was also diagnosed to have a papilledema. So patient was under these medications, and as such, she did not complain of any kind of dryness or any other symptoms. Upon our examination, her presenting best corrected visual acuity was 624 and N8 in right eye and 3/60 N10 in the left eye. Upon further investigation, left exotropia, abduction limitation in left eye was found, color vision deficiency, and slow jerky nystagmus was noted in the both eyes. And Upon anterior segment evaluation, right eye was within normal limits, whereas in left eye, tarsography and a minimal superficial punctate keratitis and a 3 mm lag ophthalmos with good Bell's phenomena were noted. And upon dry eye evaluation, it indicated a severe aqueous deficiency dryness along with a partial obstruction of puncta, and further fluorescent clearance test also indicated a reduced tear volume and tear flow. And upon posterior segment evaluation, a constructed fields and post-papilledema optic atrophy was noted. So the impression was post-papilledema optic atrophy in both eyes with a 7th nerve palsy due to CPA tumor exertion. And as a first-line management here, we asked her to continue with the lubricants and tape the lids in the night. And further, patient was referred to the low vision aid clinic. And in low vision clinic, currently patient was working in a bank and patient was in a stage of readiness for acceptance, but was highly worried and complained about the occupational difficulties as listed here. Her major need was better computer use, better mobility, better near vision, and the ability to see the bright light more. So post-trial, a penhole magnifier, clip-on green filter, and various strategies to enhance the contrast and eccentric viewing with head scanning technique and lifestyle modification was explained. And patient was counseled strongly and motivated. And patient was advised to come for a review after 3 months, but patient turned back within 2 months with the complaints of itching, dryness, and redness. And with the lubricated eye drops, patient reported to feel better, but patient also reported that it feels cumbersome to install the eye drops 18 times in the workplace. And in terms of visual management, patient was quite well happy and with head scanning and with the low vision aids. And upon our evaluation, it was same as the initial visit, but in the current visit, patient was able to read 660 through head scanning and eccentric viewing. And in anterior segment evaluation, superficial corneal punctate keratitis was increased when compared to the previous visit. And this was the image of the patient. And if you see, the patient was further referred to the contact lens department, and in which the palpebral fissure height was 6 mm in left eye, and in slit lung stage 4 SPKs were noted. So based on this, a scleral lenses of 16 mm diameter and 2.6 was applied on the eye. And in terms of nystagmus, there was a mild jerky nystagmus, but it was a better control in this primary case. And the best corrected visual acuity was same, but the patient reported a significant relief in ocular dryness post-insertion. And the fit assessment was performed post 3 hours and 6 hours of scleral lens wear, in which the central vault was excess, and in terms of nasal vault was good, and in terms of temporal vault, it was good when we lift the tarsography, but post removal, we saw a microcystic edema with limbal staining and impingement in the 10 to 8 o'clock position and in the opposite position. So this could be suspect because of the tarsography giving a pressure, and we modified it with temporal vault and the impingement. And this was the final lens where they dispensed, where there was no limbal staining and the vault was adequate. But the cumbersome part was patient was not able to insert as the tarsography was present. So to overcome this challenge, we gave her a illuminated stand where she was able to perceive the lenses and insert it by herself. So during a review visit after 6 months, patient reported a significant improvement in the visual quality and the ability to perform her daily task. So this was the initial visit, and this was at the review visit after 6 months, where we saw a significant reduction in the SPKs and a clear ocular surface. So I would like to highlight that this case report highlights the importance and the role of low vision and scleral lenses in managing these ocular conditions, where numerous studies have proven the efficacy of low vision aids in Stargardt's disease, optic neuropathy, and scleral lenses' roles in managing irregular cornea and ocular surface disease. We provide evidence for successful putting scleral lenses in this complex condition and need of comprehensive evaluation and fitting strategies like improving the decay of the material and assessing the limbal vault properly. And to conclude, this case highlights the role of low vision and scleral lenses in managing ocular complication arising post-CPA tumor exertion and highlights a fitting technique of scleral lenses in such ocular condition. I'd like to acknowledge these people. Thank you.
Thank you, Janani. It's a very nice presentation. I would like to know, like, what was the main, like, binocular status of this patient? What was her, binocular vision complaints? Did she experience anything because she had nystagmus and.
Ma'am, in terms of binocular vision, the patient's field of view itself was reduced. Like there was total field loss, advanced field loss. As such, she was not able to perceive the initial stage. As such, she was not able to perceive 6/60 also. So 3/60 with effort, she was able to perceive in one eye, and other eye was fine, but still restricted field was there. So as such, we didn't find any kind of binocular vision anomalies due to the nystagmus or any other symptoms, but we found a mild difference in nystagmus clearer lenses, which we suspect of dampening of nystagmus through the sensory feedback from the lens edge and the lid's interaction.
Interesting. Thanks.
And very impressive management from the contact lens aspect. But when the other eye has a relatively decent vision, why was this case thought to be handled in the low vision clinic?
Ma'am, as I presented, the other eye's vision was yes, distance vision. We have not managed anything as such for in the low vision clinic. So the main complaints for her was the near vision. She was not able to do the signing in the like in the check or see the computer monitor screen properly. So for that, we have counseled the patient. And due to the optic atrophy, her contrast sensitivity and sensitivity and the glare was high, and as I reported, the color vision also was found to be deficient. So for that, how to enhance the contrast and how to improve the daily activities, we have counseled for that.
No, vision in the
distance
right
vision,
eye
we
is
have not.
6/9. If I am not right, if I am not wrong, right?
No,
6/9 in the right eye, no?
For the
Right eye? What
yes,
is the vision in the right eye?
6/24 it is, ma'am.
6/24.
Yes, ma'am.
In your case study, I believe you have written it as 6/9.
No. 6/24 in the
Best
right.
corrected visual acuity was 6/9 in OD and 6/60 in OS.
No, that was post-op. Like the previous investigation report, which patient had showed like post-surgery, she had 6/9 in right eye and 3/60 in left eye. During that time, she had a papilledema, but now the papilledema has progressed, causing to the pale disc and optic atrophy, which has caused a reduction of vision and the field construction in both eyes. So as such, for distance, she was comfortable. We didn't manage anything for the distance. The main complaints for her was near vision. For that, we have referred her to the low vision clinic, and we have provided, like her, she was a banker, and we have provided a software named Magic, where we can enhance the font size, change the contrast sensitivity of the desktops, and make her to work better.
Thank you.
Yes, ma'am.
Thank you. Now, Optum Varsha Harinia M is available. Case number 018. Optum Varsha Harinia M, case number 018.
Is my screen audible? Sorry, am I audible?
Yes,
is my
yes,
screen
perfect.
visible?
Perfect.
Okay. Can I start, sir?
Yes, you may.
Okay.
No, we don't see her slides. I think I am seeing a different slide. Yeah. Okay. Now it's there.
Okay. Thank you. Okay. Good afternoon, everyone. I'm Varsha Harinya. In this presentation, we're going to see the management of shadowing of images in dim illumination with contact lenses. These are the abbreviations that I've used in this presentation. Moving on to the introduction. Visual acuity of 6/6 is universally accepted as standard vision for standard normal vision. However, patients with 6/6 vision may still report with visual disturbances when they have ghosting, shadowing, or diplopia that can significantly affect their quality of life. As you can see in this first image, the letter E can be perceived like this. And in second image, we are able to read the text, but the quality is poor. So when the patient is presenting with the symptoms like this, the first step is to identify whether these symptoms are binocular or monocular. Monocular diplopia usually persists even after the occlusion of either eye. Aberrations can be one of the factors of monocular diplopia, which can be caused by several anatomical and optical factors starting from irregularities in tear film retina. So this case report discuss about an approach to identify the cause of monocular diplopia and its effective management with contact lenses. This is the case of a 36-year-old male with a complaint of intermittent headache and diplopia at distance for the past month. He gave a verbal history of amblyopia in left eye since childhood, and the patient had a history of trauma in left eye 1.5 months before, and he had already used contact lens in the same eye. Other histories were normal. On examination, his objective refraction showed minimum 0.5 cylinder in both eyes, but he accepted plano in right eye, with which he read 6.6, and with plus 2.25, he read 6 by 24. Pupillary examination revealed normal findings in OD, but in left eye, he had mid-dilated pupil and irregularly shaped, as you can see in this image. And this pupil was sluggishly reacting to light, but there was no RAPD, and the color vision testing was also normal. Other findings, as are mentioned here. Since the patient had diplopia, he was referred for a binocular vision clinic for further management. In binocular vision clinic, various tests were performed, such as stereopsis, Watford, or diplopia charting. All these tests strongly suggest that suppression of the left eye. So, it was suspected that the amblyopic left eye might be contributing to visual discomfort when viewing through both eyes. So, to improve the vision of left eye, considering his age, a trial of just patching given for 4 to 6 hours with intense near work and with follow-up of 3 months was prescribed for this patient. So the patient returned for the follow-up in 2025 only, and he reported a worsening of the symptoms over the years. During this visit, the patient clearly reported monocular diplopia as it persisted even with either eye closed when tested. However, even in this visit, the patient did not accept any cylindrical power, and rest of the findings were similar to the last visit, with very mild cataractus changes noted in the right eye. The patient was referred for contact lens clinic for further management. In contact lens clinic, preliminary examination was taken and the values as mentioned here. Left eye had pupil irregularity, but the patient was more symptomatic in the right eye. At first, projection chart, vision check was done with projection chart where the light background with dark fonts will be there, but the patient did not report any shadowing on that. On further inquiry, the patient reported more difficulty in dim illumination and in black background with white fonts. Hence, vision was checked with the same. These are the parameters of the type C prosthetic lenses which was done. This is the picture of the type C lenses with different aperture size. So the trial was done with each of these lenses in both eyes in dim illumination and as well as normal illumination. Both eye patient felt significant reduction in shadowing, but the right eye had restricted field of view with 3 mm pupil size. Left eye did not have any significant difference between the different aperture size and different illumination. So the patient still has residual shadowing present in the eye. So we referred for eye trace to rule out the possible aberrations. As you can see in this image, the right eye had more higher order aberrations than the left eye, which correlated with the complaints of the patient, most of which were contributed by cornea rather than internal. Hence, RGP trial was done with the parameters mentioned, and it showed a good fit and over acceptance as mentioned. And the patient did not report any shadowing in both the illumination. But the patient was not comfortable with the RGP. And since even with type C lenses, the patient felt significant reduction in shadowing, the patient opted for type C prosthetic lenses. So finally, we prescribed him with these parameters. And in the dispensing with visit with proper training, the lenses were dispensed and overseal RX for reading was prescribed. And during follow-up, the patient reported significant improvement in his quality of life. Moving on to the discussion, aberrations refer to optical imperfection that prevent proper focus of the image to the retina. Many published evidences states that higher order aberration cannot be corrected with spectacles, but can significantly deteriorate quality of vision, which was noted in this case as well. This current case, despite her having irregular pupil in the left eye, the patient was more symptomatic for the subtle ocular changes in the right eye. This may be because the right eye may be functionally dominant with good vision, with other eye being amblyopic. And most of the existing literature predominantly discuss about the effectiveness of type C lenses and RGPs in mitigating monocular diplopia and aberrations in pathological eye. Only few articles expose its use in the normal finding eye. Especially type C lenses with normal finding eye is underreported, and this case adds to the growing evidence. And utilization of this diagnostic tool like eye trace played a crucial role in confirming the aberration source. And interestingly, this patient had more disturbance in dim illumination and the black background. This might be because of the increased pupil size. And since this patient was intolerant to RGP, prosthetic contact lenses was tried as an alternative. But this patient has, during follow-up also, this patient reported satisfaction with type C lenses in his daily activities. But if the symptoms had persisted, other options should be considered. So we can try, if he's not comfortable with RGP, we can try piggyback or scleral lenses. That has to be explored. So I want to conclude saying that 6/6 vision does not always equate to perfect vision. After ruling out binocular component, if the patient still has diplopia, aberration should always be suspected. And a very important take-home message that I want to give from this case is that apart from the expensive diagnostic tool, a simple installation of varied contrast charts may be very useful in management of patient like this. Thankfully, we had a black background chart in our clinic. Otherwise, the effective management of this patient would be questionable. And holistic approach involving different departments, instruments, prioritizing the patient-specific needs are highly important for effective management of the patient. I would like to thank my colleagues. Thank you for the opportunity.
Thank you, Varsha.
Thank you, ma'am.
Very interesting to see, diplopia in an amblyopia patient. And I'm curious to know, like in eye trace, did you actually check the aberrations in different zones, like the central 3 mm and 6 mm, or it was just in a specific zone that you tested?
No, ma'am. Both the 6 mm and 3 mm was taken. In both, in 6 mm, the aberrations was more, and in both, corneal contribution was higher, ma'am. In right eye, especially.
All right.
Thank you, Varsha, for that wonderful presentation. I think you have covered it in depth. We'll move to the next presenter.
Thank you, ma'am.
Thank you. Next, after Manikandan C, case number 022. After Manikandan C,
Yes.
case number 022.
Hello, sir. Am I audible? Hello, sir. Am I audible?
Yes, you are audible, but the screen displays like Varsha's screen is displaying. Okay.
Now it's audible, sir.
Yes, you are audible.
Okay, sir. Good afternoon, everyone. I am Manikandan, working as a community optometrist at Elite School of Optometry, Shankar Netranaya.
Excuse me, it's only Varsha's screen for me.
I think there's a lag in your system because we can see Manikandan's screen.
Can I proceed, ma'am?
Yes, ma'am.
Presenting on a case about unilateral high myopia with severe visual impairment. Myopia has now become a major public health problem. By 2050, expecting half of the world population to be myopic, and in India, expecting about 48.14% of children between the age of
5 and 15 years to be myopic. 10% of all myopes are expected to develop high myopia. High myopia can even corrected lead to risk of developing amblyopia, retinal detachment, among other complications, leaving the children requiring a care for lifetime and can cause severe impact on quality of life. Next, we move on to community. A 13-year-old male child studying in 8th grade was assessed during comprehensive school eye screening program in Chennai. His presenting visual acuity was 0.8, 6 by 36 in right eye and 0.2 with 6 by 9 in left eye. Objective refraction and previous class prescription showing minus 10.5 with minus 280 and minus 2.5 with minus 0.75, 10. And the subjective refraction reveals minus 10 with minus 2 SIL across 90 in right eye and minus 3 with minus 0.5 SIL across 10 in left eye. His best corrected visual acuity was 6 by 36 in right eye and no improvement with below. And in left eye, 6 by 9, no improvement with below. Cover test reveals right converging squint. Upon noticing unilateral high myopia with right converging squint, parents of the child was contacted over phone, and after a brief history, optometrist explained about the condition and counsel. As advised, the parents brought the child to the hospital within 2 weeks for further examination. Final class prescription was given minus 10 with minus 2 SIL across 90 in right eye and minus 3 with 0.5 SIL across 10 in left eye. IOP seems to be normal. Cover test showed right converging squint with the Watford dot test revealed right suppression. Fundus examination showing large myopic disc ratio of 0.7 in right eye and 0.6 in left eye with temporal pallor. Excellent measurement was done using IOL master. Excellent in right eye was 27.40 mm and in left eye was 24.41 mm. Lens thickness in right eye was 3.32 mm and left eye was 3.25 mm. Anterior chamber depth was 3.90 in right eye and 3.9 in left eye. Keratometry values showed 44.03 at 85 and 44.57 at 175 in right eye and 44.64 at 3 and 45.16 at 90 in left eye. The child was diagnosed as unilateral high myopia with strabismic amblyopia. Glasses was prescribed in the hospital with part-time occlusion for left eye, 3 hours per day, and 3 months review was advised. Moving on to discussion. Spectacle or contact lens is the first line of management for high myopia to prevent amblyopia. In unilateral high myopia with amblyopia, spectacle or contact lens along with amblyopia therapy is effective. Early detection and intervention is important to reduce other complications and to improve the quality of life. Regular follow-up is must and to monitor the child visual prognosis. High aspherical lens can be used to slow down the progression of myopia. So here the take-home message was, school eye screening is effective in identifying such unilateral conditions early. Early detection and counseling is key. Proper referral management and follow-up on referral. Stakeholders' involvement for improved eye care seeking behavior. Thank you.
Thank you, Manikandan.
Yes, ma'am.
Yeah, please go ahead. Please go ahead.
No, ma'am. If there's no questions for you, we will move to the next presenter.
I felt the same.
Yes, ma'am. Thank you. Thank you, Manikandan, for your.
Thank you.
Thank you. Next is Optometrist Deepak Kumar, case number 023. Optometrist Deepak Kumar, case number 023.
I'm audible, sir.
Yes.
Can I start, sir?
No, your voice is feeble.
Can I start, sir?
Yes, yes, please.
Good afternoon, everyone. I am S. Deepak Kumar, working as a community optometrist at Elite School of Optometry, Shankar Nethralaya. Today, I am going to present a case of a keratoglobus which is identified in a school-age screening program. Keratoglobus is a rare non-inflammatory corneal disorder with associated. 1 minute. Can I start from this first, sir?
Okay, please.
Can I start from this first, sir?
Yes, please. I think there's an
Optum
echo in
Deepak,
your
your voice
voice.
is not audible.
Can I start, sir?
Yes, please, go ahead.
Yes, sir. Good afternoon, everyone. I am S. Deepak Kumar, working as a community optometrist at Elite School of Optometry, Shankar Nethralaya. I am going to present a case of keratoglobus which is identified in a school-age screening program. Keratoglobus is a rare and non-inflammatory corneal disorder associated with thinning and globular protrusion of cornea. It is important to diagnose this condition early and have the patient under regular follow-up to avoid a deterioration of vision. This case report presents a 7-year-old female diagnosed with keratoglobus with high myopia during a school-age screening program conducted by the institution. Firstly, our school-age screening protocol has 3 phases: phase 1, 2, and 3. In phase 1, vision check was done and with a pocket vision screener measuring the visual acuity of 6/9. The child failed to read the PVS. Then the anterior segment evaluation done with a torchlight. Cornea showed a Munchen sign and sclera showed a bluish sclera. All others were normal. The child was referred to the phase 2 for further evaluation. The child's presenting visual acuity was 6/15 in both eyes. Objective refraction showed scissoring reflex with a refraction value of 6 with -5 sil at 20 in right eye and 6.5 sphere with -6 sil at 160. And subjective refraction was found to be the same as a PGP. Here, best corrected visual acuity was 6/15 and vision didn't improve further with pinhole and lenses. Further, in the management stage, the glasses were not prescribed as there was no significant change from the previous glass prescription, and the best corrected visual acuity was also the same as vision with the previous glasses. The child needed a referral for corneal evaluation, and a telecounseling was made to parents to explain the condition and need for referral. And the parents knew that the child has to wear glasses, but not about the prognosis and requirement management for the condition. And the optometrist clearly explained about the condition and the need for the corneal examination at hospital and a regular follow-up. The child was referred to the cornea department and the child visited the hospital after 39 days of referral. On your examination at hospital, the objective refraction was same as the outreach camp and the best corrected visual acuity was 6/15 the both eyes and no improvement was found. Slit lamp findings revealed corneal thinning and blue sclera in both eyes. Manual caltometry values showing the steepening of corneal curvature with oval shaped and doubling of Myers. Pachymetry value of OD and OS was found to be 269 and 266 microns, showing the thinning of cornea generalized. A diagnostic procedure pentagram was done, which showed corneal thinning in all quadrants and steepening of corneal curvature. With these evidences, the child was diagnosed as keratoglobus of both the eyes. At the management stage, the child was advised to use the spectacles with polycarbonate lenses for safety and advised to avoid eye rubbing. A follow-up visit after 6 months was also advised to check for the progression, and the teleconsultation was done to the parents after 2 months. And they were counseled to bring the child back for the follow-up. Moving on to the discussion part, previously we saw the child was managed and prescribed only with the glasses, not any other treatment forms. Even though the keratoglobus has different treatment options like contact lens or CXL, it may vary depends upon the severity and the progression. The child had a mild visual impairment and was comfortable with the glasses. Contact lens trial was not done due to the risk of globe perfusion, considering the thin cornea. Some studies showing that significant improvement in BCVA and stable keratometric reading with corneal cross-linkage, but this child has not The child has been advising on the follow-up, and the decision for the CXL will be made during a follow-up visit based on the severity and progression of the condition. As optometrists, we play a major role in early detection of ocular conditions and referral in community outreach program, ensuring that the complications were avoided. We also play a crucial role in providing optical correction with spectacles, contact lenses, which is important for conditions like corneal ectatic conditions. Optometrists play an important role in counseling the patients or the parents in the community outreach to ensure the compliance to treatment, referral, and the follow-up. So finally, this case report highlights the importance of providing a proper counseling and explaining about the condition and treatment modalities, which made the parents realize the importance of regular follow-up. Further, as an optometrist, we have a bigger role in identifying, diagnosing, managing, and counseling about the ocular condition to ensure the regular follow-up and compliance to treatment given. I'm finished with my presentation, sir. Though it's late, happy World Optometry to all. Thank you.
Thank you, Deepak. I think you are the only person who wished World Optometry Day to all of us. Thank you so much for reminding us
Thank you.
the very purpose of this presentations today. I just have one quick question. Like it was a very important topic actually, although it's in the end and we are all rushing. I would like to know, like, how do you, as a community optometrist, how do you ensure that the patients are complying to your advice? Like, say for example, you said in this case, the child should not rub their eyes. You have counseled the patient and the parents. How do you
Yes,
ensure
ma'am.
that the child is not rubbing? Like, in your opinion, what do you do?
Actually, first step we counseling the parents about this about the awareness, and we ensuring by follow up their condition, ma'am. We doing a follow up call asking whether the student child that came for the hospital for the follow up, how is the vision, and is regularly using the spectacles or not. So we telecounseling the patient to ensure the condition of current child condition, ma'am.
All right. Thanks.
It was a wonderful presentation, Deepak. I appreciate your
Thank you,
efforts.
ma'am.
Beyond identification, what more you could do for this case?
Actually, we have to insist for the regular follow-up only, because if the visual impairment is so very mild, so we can do a regular follow-up for the to check the progression and for the other treatment modalities, ma'am.
What other treatment modalities you are looking at?
If the condition is progressing, we can maybe see for a corneal cross linkage to halt the condition, ma'am.
What is the role of contact lens here? Can you think
Actually,
about
we are
the
not
role of contact lens?
Yes, ma'am. We can prescribe contact lens, but as the cornea is very thin and sclera is looking bluish sclera, and we also have a vision is a very mild impairment, so she was more comfortable with her glasses, so we didn't take a CL trial, ma'am.
Thank you, Mr. Deepak. And happy World Optometry Day to you and all the participants here.
Thank you, ma'am.
Thank you. Thank you, everyone. Anything apart from this, Optum Veena ma'am and Optum
I would just
Palamari.
like to congratulate all the presenters in today's talk. Uh, I, I would say that, you know, I learned a lot from this entire presentation, and all the cases, individual cases, were very interesting, unique, and I would also like to, you know, congratulate the people who actually shortlisted these cases to make this the one of the most interesting, you know, presentations till now. And there is I mean, of course, when there is a competition, there is always going to be a winner. So it's nothing that, you know, if you have not won it, it's not that your presentation or the case was not good, but everything was unique and good. So that's all I would like to say. Thank you all for your attention and your time. And Thank you, sir,
Thank you.
for, being a moderator and, keeping everything under control. Thanks.
Thank you, ma'am. So as we come to the close of this insightful World Optometry Day case report competition, so I would like to take a moment to express our heartfelt gratitude on behalf of OATN, Optometric Association of Tamil Nanbargal. First and foremost, a huge thank to our esteemed judges, Optum Veena Rao ma'am and Optum Valarmadi ma'am, for sharing their valuable time and expertise and also constructive feedback. So your insights have made this competition a true learning experiences for everyone, ma'am. And also a special appreciation to all our participants. Your dedication, your efforts in presenting these cases reports were really commendable. So each case showcased the depth of knowledge and clinical understanding that will shape the future of optometry. And also I would like to thank the organizing team and everyone working behind the scenes. So thank you for ensuring the smooth execution of this event, and the commitment to advancing optometry education is truly inspiring. Thank you everyone. And finally, to all the attendees, thank you for joining us and being a part of this celebration of World Optometry Day. Let's continue to learn, grow, and contribute to the world field of eye care. And also I would like to thank most of the senior members have joined the sessions, and also the expertise were joined the sessions. We would like to thank and honor them. That's a very big privilege to us. And also we will announce the results this coming Sunday, and we will keep you posted. Additionally, we have an announcement that there will be 3 other sessions happening today at 2 p.m. and tomorrow at same like 11 a.m. and another at 2 p.m. So the link will be shared via email. So anyone interested are welcome to join the sessions. So wishing you all success in your journey ahead. Stay connected, keep learning, and let's make a difference together. Thank you. Have a good
And
day.
I just have one quick thing. I'm so glad to see so many optometrists part of OATN who has been like doing an excellent and amazing job in keeping all of us together. And I applaud their contribution to optometry. And I really thank OATN for giving me this opportunity. Thanks.
Thank you, OATN, for the opportunity. For want of time, I will stop here. And people are waiting to move for the next journey. And all the best for the celebration to OATN.
Yes, ma'am.
Thank you so much, Dr. Balramati and Veena, ma'am.
Thank you.
And best wishes to all the presenters, and a very happy World Optometry Day to all.
Thank you, President ma'am, for your final touch.
Thank you. Well conducted. Thank you so much, Sam.
Thank you, ma'am. You're welcome, ma'am.